Dr. Mohan K. Abraham is Professor and HOD at the Department of Pediatric Surgery and Pediatric Urology at Amrita Institute of Medical Sciences, Kochi. His areas of special interest include pediatric urology and fetal surgery. He is the author of Basic Trauma Life Support books and chapters in other various books. We welcome you, sir. And the moderator of the session is Dr. Sridhar Sandhanam, Professor and HOD at Department of Neonatology, CMC, Vellore.
Good afternoon, Dr. Mohan. Warm welcome to you. I think without any further ado, I think we'll start your talk.
Respected chairpersons and friends, I'd like to thank Manoj and team for giving me this opportunity to talk to you on fetal surgery. Some of you may be thinking, why fetal surgery in a neonatology forum? And the reason is, the first thing you need to start a fetal surgery program is an excellent neonatal team and nursery. Because these babies are going to be born premature, and it is in the hands of the neonatologist to make them survive. I can do a beautiful surgery, but if the neonatologist is not going to take care of the baby, you have a dead baby in your hand. Now, what are the principles of fetal surgery? If you can relieve the urinary obstruction before kidney damage occurs, we can save the kidney and the baby. But in the enthusiasm to do that, we should not harm the mother or the fetus. The mother will need, if it's an open surgery especially, mother will need cesarean section in all subsequent deliveries, and the fetus is going to have premature delivery. So you need to really weigh the pros and cons before you embark on fetal surgery. We come to a few conditions. One is a twin transfusion syndrome, and I'm sure many of you will be knowing about it. It happens in a monochorionic team where twins share the same placenta. The whole blood from the placenta goes to one twin that dies of overperfusion and cardiac failure, while the other twin is deprived of perfusion and it dies of IUGR. So what we do is okay, so you can see it playing. I'm going into the amniotic cavity now. You can see the vessels that is crossing. What we do is all those vessels that is crossing between the two cords or anastomosing between the two cords, that is what we coagulate. So not all the vessels, because if there are some vessels which is supplying the donor twin, and if you are going to coagulate that, whatever the little blood supply the donor twin is getting, that also will be interrupted. So any anastomosis between the two cords, that is what is being coagulated. This is a diode laser. It just coagulates and does not break the vessel. What are the postnatal concerns for the neonatologist? See, donor twin has a less amniotic fluid, and we do this usually between 18 to 26 weeks. That's the time where TTTS manifest, and we need to go in. By then, some amount of pulmonary hyperplasia might have occurred to the donor twin, which has got severe oligohydramnios. So that's something which you need to remember. We come to fetal hydrothorax, and this is a shunt that we are using. That's a shunt we are using. It's called Harrison shunt. And these are the rest of the armamentarium. And sorry. Okay. I'm going into this is a mother's abdomen under local anesthesia. This is a Cook introducer that you are pushing it in, and it is monitored under ultrasound. And you can see it going into the fetal chest cavity. Then you push the stent in. Stent has been straightened by putting the guide wire through it. So you push it in till it enters the chest cavity. And once it enters the chest cavity, just remove the guide wire and push the stent in till you get the coil. You can see the coil there. And then you put so one coil comes inside the chest and the other coil remain inside the amniotic fluid. So thereby the chest is decompressed. And once it is done, you can just pull out the tube. Now, again, this child has something like a diaphragmatic hernia, as a space-occupying lesion, and prevents the pulmonary growth. So you have to worry about pulmonary hyperplasia. Now we come to posterior urethral valve. The antenatal management is vesicominotic shunting or fetal endoscopic valve ablation. Now, the indications, every baby with PUV or posterior urethral valve does not need intervention, because some of them can be born naturally and can be managed well postnatally. So the indication is a deterioration of the renal function as indicated by oligohydramnios. And you know that the urine of the baby is amniotic fluid. So if there is a reduction in the amniotic fluid, means the kidney has already started failing. So that's the time when you go in. And how do we know that kidneys are salvageable? Because they have got oligohydramnios, maybe the kidney has already conked off. How do we know? So we do 3 bladder taps. You just put a needle into the bladder of the baby, aspirate it dry, discard that urine. Then you repeat it 48 and 72 hours interval. And you look at these electrolytes, sodium, chloride, and other things. And if there's a progressive fall in the values, the reason is the fetal urine is hypoosmolar. So if there is a progressive hypoosmolality setting in, that means the kidney has some function to recover. So the first thing that was started was shunt technique, and it's almost the same as that you saw for the hydrothorax. The baby's position has to be supine. You paralyze the baby, put the cook introduce, and put the tubing in. Now, there was a last study called Pluto study that was conducted. They found that the 28-day survival and 28 days and 1 year survival appears to be higher with VAS. So this is because of an improved pulmonary function, but the renal function could not be proved beyond doubt. So then people thought of endoscopic valve ablation. This is antegrade visualization of the valve with the fetoscope, fulguration of the valve with laser. But this is possible only before 24 weeks because the bladder and the urethra, the angulation becomes so acute that you cannot get into the posterior urethra. So there was a comparative study comparing fetal cystoscopic valve ablation and vesicominotic shunting, and they found that fetal cystoscopic valve ablation improved both 6 months survival and renal function, whereas amniotic shunting improved only the pulmonary function and 6 months survival. So as of now, the gold standard is fetal cystoscopy and valve ablation. Now, again, this is done under local. There's a curved fetoscope that is going into the abdomen and then into the uterus and into the baby's bladder. You can see it on the ultrasound. It's jabbed in, and once it is in the ultrasound, once it's in the bladder, you put your fetoscope telescope in. And as I'm going in, there's an angulation I was talking about. You are going into the posterior urethra. It's really angulated there. You go in till you find the diaphragm that is obstructing the posterior urethra. And once you find that, you make sure it is a diaphragm and not the posterior urethral wall that you're mistaking. So you just push it with a laser fiber. It's a diaphragm. You can just push it down. So then you apply a laser energy and make multiple holes. And once multiple holes are made, you join them together. So once you get an adequate opening, remember this opening will be a little larger than what it appears to be because there's a little bit of burning will be on the side also. So once you get that thing, then you can pull out the fetoscope. And the post-op, we give you nitroglycerin 5 milligram for 24 hours and nifedipine retard 3 days, which you may to continue if there is any instability of the uterus. Postnatal concern, again, pulmonary hyperplasia, because they had oligohydramnios before we took them in. Prematurity, because all of these patients go into premature labor from 10 to 14 weeks after the intervention. We do not know why. Diuresis. It's not only positive diuresis. These children have bad kidneys because only with bad kidneys we are taking up for valve ablation. So they have a high output renal failure. So they'll be passing a lot of urine which we really have to supplement. Otherwise, they will die of pre-renal failure rather than the disease with which they came. Now come to sacrococcygeal teratoma. The cystic tumors are less chance of hydro because they have less blood supply. and you prepare them with indomethacin and inhalation anesthesia. Then this is a open surgery where the uterus is already been exposed, and sorry, how do you play this? Okay, so the tumor is delivered out, the baby remains inside the uterus, otherwise the uterus will contract and we will lose volume. And once the tumor is removed, the baby is pushed back in and the uterus is closed in 2 layers. And then the post-op, we have to give really good maternal post-op care with epidural analgesia, indomethacin, magnesium sulfate, loading dose of 6 grams, and then tapered according to the status of the uterus. Then oral nifedipine is continued. Now, a single course of betamethasone is given in anticipation of preterm labor. Complete excision of the tumor is done postnatally, because normally we have to excise the coccyx also along with that, because that's the origin of the tumor, which is not done in the fetoscopic, I mean in the antenatally, but it is done postnatally. Postnatal concern, again, prematurity, as I said, they all go into premature labor. They may have anemia because they would have lost some blood, and of course another neonatal surgery after birth. We come to CPAM. And this again, the compression by the mass leads to hyperplasia of the normal lung tissue and cardiovascular compromise, leading to fetal hydrops and death. Now, esophageal compression produces polyhydramnios. Now, the important thing is the mother develops what we call a maternal mirror syndrome. The mother mimics the hydrops that the baby is developing. And then even if you do the fetal surgery, the preeclamptic state does not regress. So we have to be very careful in monitoring these babies and the mother. And if there is any eye drops developing, we need to go in and take the tumor out. And this again in open surgery, you expose just the chest, open the chest, remove the tumor and close the chest. Antenatally, a betamethasone 12 milligram intramuscularly, 2 doses 24 hours apart does wonders. We had many patients in which the tumor really regressed, which was not even visible in X-ray postnatally. But then we had to do a CT to confirm that it is there. So it's a very helpful thing. But if it doesn't work, then you have to do the fetal lobectomy. Now, this child had a hybrid lesion with a blood supply from the aorta. We went in with the laser, coagulated this abnormal blood supply, and the tumor shrank. The baby was going into hydrops, and we could prevent that by just coagulating that. And we have published this already. Now, the concern, postnatal concern, again, prematurity and pulmonary hyperplasia, because this again is space-occupying lesion in the chest and compression of the lung creating hyperplasia. Come to another controversial area, myelomeningocele. There are damages because of the defective development of the cord, plus injury by the amniotic fluid and the displacement of the spinal cord, producing tearing of the roots. Now, the last two is what we are trying to abort or prevent through surgery. Now, the timing of surgery is done about before 24 weeks of gestation or 25 weeks of gestation, because myelination occurs during 15 to 24 weeks. That is where we can expect some regeneration if we do the surgery. There was a large study called MOM study conducted in States. And what they found was, if you do antenatal surgery, the shunt requirement is about 50% less than the postnatal surgery group. Hindbrain herniation is also again 50% less than the postnatal surgery. And walking without support was almost double in the prenatal group. But the problem is we cannot tell the mother that we can give you a normal child. And most of the time when the parents hear that, they opt for MTP. Postnatal concern, need for monitoring renal status, because they have neurogenic bladders, and kidneys may be having normal function at birth, may deteriorate during the course of events. So the problem is we are not watching the stream, because they are all in the nappies in the NICU and later on with the parents. And they may have dribbling, they may have a distended bladder which go unnoticed till the kidney is discharged. So that is one thing that we have to take care of. We come to FETO. Here, a detachable balloon is introduced into the trachea, is inflated for 4 to 6 weeks, and then deflated at about 34 weeks. So the mucus secreted by the lung remains there and distends the alveoli. And that is how the lung growth occurs. Trocalitis are given antenatally, I mean, before the surgery. Now, this is the thing we use, this balloon we use, costs about $1 lakh. And you can see the video. I'm going into the amniotic fluid cavity. That's a nose that you're seeing on the baby. You go into the mouth. You use the tongue as your guide. Go behind the tongue so you see the epiglottis. Then a little trick, I mean, little jerk, you get into the trachea. That's the trachea. You can see the carina there. And once you confirm that, then you put your balloon in. And there's a balloon going in. And you inflate the balloon with about 0.6 ml of saline, and then just pull on the stem. Balloon stays there and the stem comes out. Now, in severe CDA, that is if the LHR is less than 25%, lung head ratio is less than 25%, then there is about, the survival is almost double, 24.1 to 49.1%. But there are complications like a tracheal occlusion reduces type 2 pneumocytes and surfactant expression. And there's some tracheomegaly, which is on a clinical impact. Premature rupture of membrane can occur up to 3 weeks and in 17% of cases. So that's a major morbidity. Now, there was a trial for moderate group where LHR is 25 to 34.9% without, irrespective of the position of the liver, or 35 to 44.9% with intrathoracic liver herniation. So FETO was done at 34 weeks, 30 to 32 weeks, and removal of balloon at 34 to 35 weeks. And the conclusion was it did not show significant benefit of FETO performed at 30 to 32 weeks. And also it increased the risk of preterm labor, pre-labor rupture of membrane, and preterm birth. So there is a morbidity, and we don't, as of now, we do not have much benefit in the moderate risk group. Now, postnatal concern, remember in the thing, the lobar structures and the bronchial airways, crude alveolar sac all occur by 24 weeks. And we are doing the FETO at 27 weeks, even in the severe groups. So by then, these airways are not developed. So there is pulmonary hyperplasia, whatever you say, even if you do FETO. So that is something which you have to think of when you're ventilating this baby. And they may also have a surfactant deficiency. Normally in CDH, we don't give surfactant. But in these cases with post-FETO, you may have to use that. Come to exit procedures. Mainly for airway obstruction like tracheal atresia or mediastinal masses or CPAM. Rapid anesthesia is given. And stage 1, inhalation anesthesia, trocalitis supplemented, maintenance of uterine volume is maintained by not taking the baby out. Fetal anesthesia is given. Now, this baby had a tracheal septum, and we diagnosed it in ultrasound because there was tracheomegaly, distended trachea and oversized lung. So I'm going in, baby is just the head and neck is delivered, the rest of the baby is still in the uterus. So that won't allow the uterus to contract and the placenta to separate. I done the tracheostomy, I'm putting the tracheostomy tube in. Now the lung is filled with fluid, so that has to be sucked out. So there's no point in trying to ventilate that with a lung full of fluid. So once it is sucked out, then you connect it to your ambu bag, and the neonatologist takes over from there. And the baby is delivered outside the uterus. The cord is clamped. So till this point, all the perfusion and the oxygenation of the baby is maintained through the cord. The cord is clamped, and the baby is handed over to the neonatologist who takes good care of it. So just before clamping the cord, the volatile anesthetics are reduced, oxytocin is given, methogen is given if needed, and maternal paralysis is reversed. Postnatal concern, again, tracheostomy care and LRT. I mean, because of this distension of the trachea, is possible a lot of ciliary function is lost. So they may have, mucus redundant in the trachea and creating LRTA. Now, I like to conclude by saying the antenatal surgery is only the beginning of the treatment, because all of them will have sequel, and the neonatologists have to take care of that postnatally. And success of having a live baby depends on the neonatologists, and so they form a very important part of the team. It's a teamwork between the pediatric surgeon, because between the neonatologist, fetal medicine, and the gynecologist, the obstetrician. So it's a teamwork. If you don't have a team, don't try it. Thank you.
Very excellent lecture, Dr. Mohan Abraham. You took a very fairly complicated topic. I think you made it sound so simple. I can understand how complex this whole thing is. And with the pictorials and the thing, I think you made it very, very, very easy to understand also. This is something fetal surgery over the past 25 years, we have sort of seen the rise and fall of fetal surgery. Initially, a lot of excitement about tracheal occlusion, then it died down. Then again, after FETO, it sort of came up and now other things are all starting. So it's really nice to see a lot of work being done in India also on this. I'll actually first start off by throwing the thing open to the audience. If anybody has any questions. I had during watching your things, sir. We have actually done pleuroamniotic shunts for chylothorax, especially. Our biggest problem when we use a pleuroamniotic shunt is the slippage of the catheter. And sometimes between 3 to 7 days only we are able to retain catheters sometimes. Is that a problem for you also? If so, how do you actually overcome this problem?
I mean, it's a trial and error. It's a problem everywhere. I mean, it's a problem with us also. It just slips out maybe 2 weeks, 3 weeks. But then you allow that time to, at least that time the lung grows. So you can put in a second shunt.
Yes. Approximately how many days are you able to extend the gestation of the fetus?
You get it 2 weeks.
Okay.
And put another shunt, you get another 2 weeks. So by then the child is able to be delivered.
So we also find usually more than 2 weeks to 3 weeks, we are not able to extend gestation and we end up delivering the baby that much. Nice. The other thing I wanted to ask, very interesting thing about mom's trial. One of the things in the mom's trial is in the control group, babies who had only postnatal surgery, the amount of shunts done in the first year of life is extremely high, more than 90%. We don't see, at least from my experience, we don't see our babies we don't do fetal surgery anyway. So postnatal, we don't see this degree. Do you see this degree of hydrocephalus and BP shunts in the first year of life in your babies? And do you practice prenatal surgery for myelomeningocele?
And there are two aspects to it. I cannot speak about it because we have a pediatric neurosurgeon who takes care of the shunt. Okay. So I cannot tell you about that. But then the thing is, this in a trial like that, every child is monitored for the development of hydrocephalus. So many of our children may have hydrocephalus, arrested hydrocephalus, we do not know. And many of them may be going, so unless until we really follow up and really scan them for hydrocephalus, we cannot say, because this is a trial, so they were scanning every child. So probably that's why the incidence is a little high.
Okay. Thank you very much for that.
And Dr. Joseph from Astamid City. Is FETO you started doing? I thought it was only on a trial basis done in one center only, or licensed to do FETO.
No, FETO for severe group, FETO is licensed. I mean, is a standard of treatment right now. It's a moderate group that is equivocal. So we are not doing for moderate group. What we have done is LHR of 30 or less.
Okay, thank you.
Any other questions? Okay. Thank you, Dr. Mohan Abraham, for a very enlightening lecture. Thank you very much.
Thank you, Dr. Mohan Abraham, for the talk, and Dr. Sridhar Sandhanam for your contributions to the session.